So again, this is another hallux limitus patient. It's a male patient though, so we're gonna probably use a little bigger, the 2.0 plate on him instead of the 3.0. So nice long incision to make sure you have adequate exposure. So again, we're just going to look for our vein and not do too much dissection here. Just undermine the vein and the nerves right below it. Just enough so we can make our capsular incision. Capsule incision, just kind of in a V along our incision. Again, this is another hallux limitus patient. We have a joint mouse kind of popping into play right away. So there's our joint mouse right there coming out. They're a pretty big piece. Gonna release the medial side of the joint here. And the plantar aspects of the base of the proximal phalanx so that we can release the short flexor tendon and really get access to the phalangeal base. Memory elevator, please. So again, I release the short flexor tendon. I'm going to free up the sesamoids here a little bit so they can retract. The McGlamry elevator. Take the saw, just kind of cleaning up the bone a little bit here. You can see a really arthritic joint with a lot of periarticular bone spurring and hypertrophic bone. And we'll go ahead, he's got a lot of spurring around the base of the proximal phalanx. I'm just going to go ahead and resect that too. Again, just minimal, not very much bone here at all. This patient also has some gout crystals in the joint as well, it looks like. Okay, take a 15 blade, please. Kind of drop that one, hold on to pull out the toe for me. So you can see all that irregular bone. I think it just helps to get a nice flat surface to work with the reamers. And we're going to just take off the distal aspect of the metatarsal head too. I'll take a rongeur first here. We'll get some of the soft tissue off the. We'll take the wire next. So again, remember your metatarsal has a declination angle, so keep that in mind when you're running your pen. So this is the larger reamer. It's going to fit him pretty well, so we're just going to pulse. You can even see with all that bone I took off with the saw, how much there's still a little overhang here. So we're gonna take a ronger and clean that up. You can see a 15 blade. A little bit of soft tissue here I'm just going to take out so it doesn't get in the fusion site. Just healthy bleeding bone there, not very little shortening. You can over shorten these and cause lesser MPJ problems, so you got to be careful with that. Again, just through the center here, not too deep, because we're going to use a 6.2 to hold it in place. And just pulse. Remember, we kind of resected the base with a saw already, so this is just to, so it fits into the metatarsal head. So we're just gonna pull the metatarsal head here a little bit. And base proximal phalanx. I'm gonna leave all that nice autograft in there. A little flesh at the end, whatever's hanging out, but we're gonna use that to our advantage if we can. Okay, we're gonna retrograde it out the center of the toe. It does, it serves like a rail, so you can compress along a rail. It just gives you, you don't have to worry about losing your position or you're trying to get everything situated. So, simulated weight-bearing surface, so that's a little lower than I would like, so there's no reason to rerun it, you can just bend it up a little bit. You want to be able to squeeze the tip of the toe so it touches the plate. So it's just off the tip. Looks pretty good. Go and retract. So this is the 2.0 plate. It's a little bigger. Works. This guy's got a little bigger foot, so this is the right size for him. The medium size. So you gotta get that retracted out of there. There you go. So it's important to get that straight on there and aligned well. This is a longer plate, so really watch that back corner that it's not swinging too far medially, because it isn't a little bit of valgus like it's supposed to be. So that back corner can swing a little medial. Apply our clamp. I'll measure. So this is a male, so we have a little more bone here to work with. Let's go 14. Again, these do not have to be bicortical, so we're just going to use one cortex, and then the plate is our second cortex. Okay. We're going to come back here and get our compression slot. So this is measuring just kind of about a 15. So you want to make sure you're longer than shorter. So let's try a 18 on him. Yeah. Again, this screw has to be bicortical. You're better off being long than short. And this is, I drilled that hole at the back, or the most proximal aspect of that oblique hole. So if the head of the screw, once it hits the plate, it's going to slide forward and give us a couple more millimeters of compression. So this is an 18 millimeter non-locking screw. This will also help pull the plate down a little bit to the bone. And I don't know if you could tell right there, it really, once it engaged the plate, it really bent the plate down a little, or pulled that plate down to the metatarsal really well. When I also put that in, the backside was a little medial, so I angled it along the lateral, kind of posterior lateral portion of that hole, so I also pulled the plate over just a little bit too. So we'll take a 16 locking here, please. And since that measured right about 16, I knew that that will be a 16 at the back there. Now again, once you put this screw in, you have maximal compression. You can't put this screw in first and then the compression slot, because once you lock on both sides of the joint, you are locked under maximal tension on both sides. You want to lock one side and pull the other side towards it, and then lock over here. Now you're locked under maximal compression. The rest is just drill and fill. So again, you pull down on the lever here to unlock that. So we have good tight screws. We'll take the K-wire out next. Can I see that freer? So you can see our fusion site. You're going to have a little gap planarly just because you're dorsiflexing the hallux, but we have good bone-to-bone contact here. Looks good. Check with the plate here after we get this out. So that's perfect. Not too straight. Toenails pointing straight up and down. Flush. Go ahead and retract for me. So those little pieces of bone that aren't in the fusion site are now coming out. We'll close the capsule real quick. So again, nothing too fancy on the capsule because it's just a fusion, so we're just going to reapproximate it. Go to whatever skin closure you like, but I just use horizontals typically. But just make sure you have a long enough incision so you can see what you need to see and get the plate on, because it needs some room. Don't be afraid to make a longer incision. Really free up the base of the proximal phalanx so you can dislocate it, so you can ream it without damaging any tissue with the reamer, because the reamers are sharp. They can cut other tissue. So make sure you have that base freed up and you're not going to be intruding upon the surrounding soft tissue. Make sure that those pins, there are 4 pins in the set, 4 tack pins. There's a small, medium, 2 mediums and a large. I almost always use the large at the proximal aspect and then the medium at the distal aspect. You do not want those pins to kind of pull out as you compress it. So you want them to be bicortical. So it's better to have them long than short. Make sure you add 2 millimeters to your non-locking compression screw to whatever you measure. And don't worry if it's long, it's not a big deal. There's just soft tissue there, it's not gonna hurt anything. The variability of the screw plate interface makes it so nice that you have to use a guide and mess around with it. Local. I recommend going ahead and get an x-ray just to verify your screws prior to closing. Okay. So I just use Adaptic 4x4s with a Halleck splint. Okay, I'll take that Band-Aid next.